Chandrima, Dr. Namrita, and AIOS for giving me this opportunity. So topic for me today is the algorithm for surgery in glaucoma. Well, I'll be talking on these particular points and we'll take it one by one. So let's take a look at general principles and indications. Well, we have different surgical techniques and there are different indications for them. So I would be just broadly telling you the principles. So the choice depends on multiple things. First and foremost, being discussed very well already, the target IOP chosen for an individual. And then we have to look at what are the previous surgeries done in a given patient, what is the medication he's on, and what is the degree of field loss, which is very well explained already, and the risk profile of a patient, and not also the preference and experience of a surgeon in a given technique. Last but not the least, it also depends on what is the patient's opinion, expectations, and the post-operative compliance that we expect. And that is how we decide what surgery we are going to do and when. So surgical decisions should be based on the outcomes of published clinical trials. So that means there has to be a evidence-based practice as far as decision of surgery is concerned. And there are multiple factors involved in an individual, like compliance or stage of glaucoma. It should be considered when medical therapy and laser fail, and it should not be kept as a last resort, because in certain patients you might have to do it earlier than what we usually do in some other patient. Angle closure glaucoma, as already mentioned, should be dealt with peripheral iridotomy first. Primary congenital glaucoma should be managed with goniotomy or trabeculectomy, or a combination with filtration surgery based on each case scenario. And when we are talking about the secondary glaucomas, the management is slightly different. You have to take care of the primary cause along with treating glaucoma. That is very important. Now, if we look at the indications as given by American Academy or European Glaucoma Society or WGA recommendations, patients where the optic nerve function is failing or likely to fail with maximum tolerated medical therapy, and we are not able to achieve a sufficient IOP reduction even with laser treatment. This also includes the failure in patients with poor compliance or due to side effects of the medication, or if the patient is not able to assess the particular medication or affordability is an issue, and there is progression of visual fields despite of pressure control. EGS in addition suggests that cases where the patient present to you with advanced glaucoma and high IOP at presentation, and where we feel that other forms of treatment are likely to be unsuccessful, can be directly taken up for surgery as well. So largely the WGA recommendation says that incisional surgery is indicated when medical therapy or laser fail to sufficiently lower the intraocular pressure, or patient does not have access to or comply with other forms of the therapy. It may also be decided based on socioeconomic or logistic constraints of the patient. Now, how do we decide for a surgery? I think this graph I will skip because Dr. Manish has nicely explained that. So what we need to understand is there are different stages of glaucoma, and what we are trying to avoid is the severe functional impairment in the lifetime of a given patient. And based on that, we take the decisions for surgery. And you always have to keep in mind that there has to be a risk-benefit ratio looked at for each individual patient, based on what is the advantage we are going to get by doing a particular surgery in a given patient and what are the risks involved. And we need to take in account multiple factors that we already discussed, like IOP control, compliance, progression, degree of damage, and the risk factors. So when we feel that there is threat to vision, and there are different dimensions to it, it may be related to age or damage or progression. And then when there is threat to vision, that is when we decide about the surgery. Well, now I'll just briefly take you through the surgical technique. Well, I'm sure all of you know trabeculectomy is the most popular surgery or most common surgery that we do. And there are different techniques. You can have a limbal-based conjunctival incision, as I'm showing here, and do a proper blunt dissection so that there are no tenons, adhesions there. And then the cautery is being done. And this is a triangular partial thickness scleral flap being marked. This dissection can be done using a 15-number blade or a crescent. The flap can be a rectangular flap or a triangular flap based on what is your preference. Even the conjunctival flap can be limbal based. This is the trabecular meshwork block marking that is being done. And then this is the full thickness trabecular meshwork block excision being done, which you can do it with banas, or you can use a Kelly sponge for creating that opening. And this is a particular method where I'm using only Bana scissors. Previously, what I used was a Kelly sponge. And then you have to do a peripheral iridotomy so that you don't get the blockage of the ostium. Once you're sure there's a full thickness iridectomy done, then you can close the scleral flap with 10-0 nylon suture. Whether you use a single suture or 3 suture, depending upon your preferences. And this is the conjunctival suturing being done with 8-0 vicryl. So this is a continuous purse string suture because I have taken a limbal based flap. And what is important here to keep in mind is always used a round body needle and not the cutting needle. Now, when do we have to combine the glaucoma surgery with cataract surgery is when the intraocular pressure is lowering is required and there's a visually significant cataract. If patient is on multiple medications or with advanced glaucomatous damage along with the cataract, well, it also depends on the level of desired IOP or target IOP that you're looking at in a given patient, the severity of glaucoma, and what is the anticipated benefit in quality of vision after cataract extraction. There is a limited evidence to differentiate between one site or two site approach for combined surgery or a limbal-based or phonics-based conjunctival flap. So it depends on surgeon's preference because the outcomes do not vary much. Mitomycin C preferably to be used in all combined surgery cases unless contraindicated. Now, when you have to combine the cataract surgery with trabeculectomy, you can do both ways, single site or two sites. So this is a single site where I did the capsular excess already. And now this is a phonics-based conjunctival flap. And then you make a scleral partial thickness scleral flap. Now, after making the partial thickness scleral flap, this is just marking of the trabecular meshwork. And after that, you can enter the anterior chamber with the keratome and do a regular phaco. So after you finish doing the phaco and put an intraocular lens inside, and then you can go ahead and remove the trabecular meshwork block to complete the block excision, like how we saw in the previous video, and then do a peripheral iridectomy. And rest of the procedure remains the same. You can use the sutures to close the scleral flap and then the conjunctiva. Now, if you have to combine it with SICS, it's very simple. You can use the same incision as you use for SICS. This is a Blumenthal type of surgery. So you take a incision 1 millimeter posterior to what you usually take, and you really don't have to make that triangular thing because it's a long incision. So after you finish removing the nucleus and putting the IOL, just in that you can do the trabecular meshwork block excision and PI, and then put the sutures, couple of sutures along the, on either side of the trabecular meshwork block excision. And the conjunctival closure is similar to what we saw in a combined surgery. So it's very simple to combine trabeculectomy along with the cataract surgery, whether it is phaco or SICS, whatever you're comfortable with. Now, when do we use releasable sutures? When you want to avoid hypotony in the initial phase, but you need a relatively lower target pressure, when you don't have to use mitomycin C because of some contraindication and you anticipate hypotony, so you want to put a releasable suture so that you can release it later on. When you're not sure of the surgical outcome due to the patient's eye condition and need to keep scope for adjusting the IOP post-operatively, that is why we call them as adjustable sutures also. And you can have 1, 2, or 3 releasable sutures based on the amount of adjustment that you would want post-operatively. However, it is not preferable in children, mentally retarded, or patients who cannot cooperate on slit lamp for removal of these releasable sutures. Now, how do you put a releasable suture? After putting an apex suture, which is fixed, then you can take a partial thickness corneal suture so that the cut end of the suture will stay in that tunnel to avoid windshield wiper effect. And then you can take a regular bite with the scleral flap. And instead of taking out that suture, you can tie with the loop that is created. And you take 4 throws and you take just 1 knot so that when you're pulling the end, it opens up. And you cut the edge close to the corneal tunnel so that you can it doesn't affect or does not irritate the patient. So this is how you put a releasable suture. And how do you release it post-operatively? Well, there can be 2 situations. You may not want to release the suture and you would want to cut it off after, say, a month or so, after which it's not going to be useful. So in that situation, you just take the edge of the suture like this and use a needle to cut it flush to the your conjunctival flap. As you can see here, this is being cut flush so that you're not releasing it. because your pressure is appropriate. In another situation where you feel that the pressure is high and now you want to release it, so just take out the buried end of the suture from that corneal tunnel where we had put it. So once you take the thread out, and then you just need to gently pull it downwards, and you can see how easily it comes out. The important thing here is when you release the suture, you have to do a Seidels test to make sure that there is no leak there. In case you find a leak, you can put a bandage contact lens, or if it is more, then you might have to take up. But usually you can get away by putting a BCL for a couple of days. Now, antifibrotic agents in trabeculectomy are very popular. I think most of us use it almost unanimously, the Mitomycin C, in different concentrations, 0.2 to 0.4. And the more field safer surgery system prefers a larger fornix-based conjunctival flap and a larger area of Mitomycin C application, so you have more posteriorly directed flow. Well, use of collagen implant is also, preferred by certain surgeons to improve the quality of bleb so that you don't get very thinned out bleb with Mitomycin C. I personally don't have much experience with collagen. Well, post-operative injections of 5-FU is something that is very interesting, and I use it often. So it is very simple. You just have to give 5 milligram, that is 0.1 ml of 50 ml solution, 50 milligram per ml solution, which is commercially available. And you just need to give injection close to the bleb on the slit lamp. 3 to 7 injections at weekly intervals is what you can do when you see congestion or fibrosis around the bleb. Now, glaucoma drainage devices. Well, when do you consider glaucoma drainage devices? They are indicated when trabeculectomy is unlikely to be successful because of socioeconomic or logistical issues. Certain glaucomas where they are used as a primary surgery is neovascular glaucoma, aphakic or pseudophakic glaucoma, uveitic glaucoma, or silicone oil induced glaucoma, or patients where you have a lot of surgeries done earlier and there is a lot of conjunctival scarring. In congenital glaucoma where angle surgery or Trab has failed, however, usage of aqueous shunts have been increasing and the indications are broadening. So they are increasingly being utilized in the surgical management. Here also, like how you have bleb failures, the scar formation around the plate is the main cause of long-term device failure. So that is what needs to be addressed post-operatively. The larger the surface area of the plate is, this is associated with lower IOP. So that is how you can choose the type of shunt that you're going to use. So I'll skip the video just to show you the broader steps, that this is how you take incision, a conjunctival pocket, to put the plate of the implant. This is the Ahmed valve or a valvular implant. Now, after you fix the implant in the conjunctival pocket, you need to put the tube into the anterior chamber and then close this tube or cover the tube with a scleral patch graft so that you don't get the tube extrusion, and then the conjunctiva is closed. Now, when we talk about valvular and non-valvular, what are the differences? You need a larger conjunctival incision in a AADI or a Baerveldt, that is a non-valvular implant, because they have to be, the flanges have to be kept under the muscles. So you have to retract the muscles and fix the implant after that. And most importantly, you have to ligate the tube so that to avoid the flow and hypotony, and the proximal part of the tube, you can make the fenestration so as to allow some drainage till the time ligature opens. So these are the differences. There are different newer surgeries, which I will just touch upon. That express mini shunt glaucoma shunt is something which is similar to trabeculectomy, where instead of doing the trabecular meshwork block excision, you put this steel implant where the flange stays outside and works as a wick to drain the aqueous, and the bleb is closed similar way. Non-penetrating glaucoma surgery where deep sclerectomy, canaloplasty, viscocanalostomy are the ones which have been mentioned. The success rate varies from 50 to 95%. However, if you see in comparison to the Trab, these rectangles are the Trabs and the solid dots are the deep sclerotomy outcomes. So you can see that they have relatively higher.
Could you sum up, Dr. Sushma?
Sorry?
Could you sum up?
Yeah. So I will just skip the cyclo-destructive surgery. These can be used as a last resort where there are non-seeing eyes or other surgeries are not possible. You need to keep in mind the complications. Well, just to come to the end, what is the algorithm for glaucoma surgery? If you have an uncontrolled IOP with maximum tolerated medical therapy, these are the options: Trab, express shunt, or NPGS. And if it fails or there are poor chances of success or scarred conjunctiva, you go to shunts, whether valvular or non-valvular, depending upon the level of IOP control that you want. And if there is poor visual prognosis or low possibility of surgery, you choose the cyclo-destructive procedures. Newer surgeries fall, the angle surgeries fall somewhere in between if you want to use them. Well, combined surgery, there's glaucoma with cataract. If the IOP is high and disc and field are normal, you do only cataract surgery. However, if there is early to moderate glaucoma and there is poor compliance or poor tolerance to the medication, you go ahead with a combined surgery. And if there is advanced damage, you prefer to do cataract and glaucoma surgery together. If the IOP is well controlled and you see early changes, you can do only cataract surgery. So, what we need to understand is interaction between the disease manifestation, treatment, and quality of life is unique for an individual. So the decision making depends entirely on an individual case. You need to look at the risk benefit ratio for a particular individual before you decide about the surgery. And trabeculectomy still remains the most popular surgery. Thank you for your kind attention.
Thank you, Dr. Sushma. We'll move on.